Great, thank you. And again, good evening, everyone. On behalf of the LAM Foundation, it is my pleasure to welcome you to the October session of our 2021 LAMposium in Your Living Room series. We are delighted to have you with us this evening or this afternoon or morning for those of you zooming in from the West Coast and other parts of the world. My name is Charlene Dunn. I am the Patient and Clinical Programs Director for the Foundation, and I will be your moderator this evening. We have a truly fantastic program ahead. Dr. Dilling, Daniel Dilling, who is joining us from Chicago, will share his insights regarding the coronavirus pandemic and its effects on lung transplantation and clinic care. Dr. Dilling will also field several excellent questions that were submitted by our patient community. Next, we will be joined by Kay Blankenship, a clinical consultant and licensed clinical professional counselor who is joining us from just a couple of hours south of Dr. Dilling in Peoria, Illinois. Kay will explore the impact of the pandemic has had on our lives, relationships, and mental health, and share ideas to promote self-care. Following Kay's presentation, we will move into our group discussion. Before we get started, I would like to take a moment to thank our generous sponsor, the National Disease Research Interchange, or NDRI, for their continued support of this educational series. A couple of housekeeping items before I turn this over to Dr. Dilling. First, our microphones will be muted throughout the presentations. We ask that you please limit your use of the chat box to questions for our speakers. And finally, for optimal viewing, I would suggest you use the speaker view option for the presentations and then transition to the gallery view for our group discussion. And now it is my pleasure to introduce Dr. Dilling, a familiar face to many in our community. Dr. Dilling is a professor of medicine at Loyola University, Chicago Strick School of Medicine, and is the medical director of the lung transplantation program at Loyola. He oversees an advanced lung disease program where patients with pulmonary fibrosis, as well as several other advanced or rare lung diseases, are under the care of a multidisciplinary team. Dr. Dilling has been a lifer at Loyola, where he attended medical school and received his internal medicine and pulmonary and critical care training. His work at Loyola consists of patient care, teaching, administration, and research. Dr. Dilling is also actively involved and engaged with the LAM Foundation. Since 2010, he is the director of the LAM Clinic at Loyola, where he now cares for well over 100 individuals living with LAM. Dr. Dilling is also a member of the Foundation's Board of Directors and serves as medical director for our Circle of Hope Transplant Support Program. He is also a tremendous support to our clinic and liaison networks. Dan, thank you for being with us this evening, and I will turn this over to you.
Okay, thanks so much for that kind introduction, and so great to see all your faces. I miss seeing so many of you in real life, and I hope those days will come back before too long. I chose not to make any slides for this talk, and it was on purpose because the last time we met was probably about a year ago, or maybe it was less than that. But at the last time we got together, I talked to you about how the pandemic was beginning to affect LAM and transplant. We talked about some new data that were really exciting about how patients with LAM have been found to have some longer survivals than the average patients who have a lung transplant. And that was heartwarming for all of us. But also the last time we talked, we were in a different place as a country, as hospitals, as patients, and as a patient community. If you think about it, 1 year ago, we were well into the pandemic. And in the transplant realm, we were just coming out of a period where a lot of us had put almost all of our patients on hold for transplant, where many transplant programs, including my own, basically stopped doing any lung transplants unless they were for the most urgent cases of people that had, that were really on the brink of death. And we stopped bringing in patients from home and everything. So those things were just changing at that point. We certainly didn't have any vaccines yet. We were trying to figure out how to continue to care for our patients in the middle of a pandemic, patients who needed to be seen, patients who needed to have pulmonary function tests, patients who needed to have bronchoscopies. And if you think about it, blowing in a small room, in a closed chamber, or having your a scope put into your airway, and all the air samples that start to flow around a room from there are a worrisome situation if you're thinking about transmitting disease around. So a year ago, we were figuring out how to do these things in a way that might be safe, or as safe as possible, and also might be still usable for the care of our patients. So we've come through this. We figured out ways to test people before their procedures, and you've all, I think, probably experienced this, where you have COVID testing prior to a pulmonary function test, and that's become almost a mainstay of how we perform those procedures. Same thing goes for invasive procedures like a bronchoscopy, but also like a colonoscopy or other kind of routine medical procedures all require testing ahead of time. So we've figured out ways to get back to normal normal workflow in our hospitals. So I'm glad to say that we no longer have patients on wait list put on hold anymore, just for the sake of the COVID pandemic. We are transplanting as normal. Of course, we test people before the procedures, and there are people, in fact, I had one just this week, a person on our wait list who became positive for COVID and has to go on hold until she gets through that. And hopefully, and it's not a LAM patient. So just a general lung transplant wait list patient who has to go on hold while she makes it through her COVID illness. And hopefully it's smooth sailing for her and many others that go into this situation. And we know that patients who are vaccinated and who do get the virus infection are a lot less likely to have a serious infection. And we also have treatments to give them outside of the vaccine once they get the virus. We have monoclonal antibody therapy, and this woman that I'm talking about had the Regeneron therapy this morning as part of her treatment course, given that she's someone who's more susceptible than the average person to having serious problems with the viral infection. So our lung transplants have largely returned to normal in their numbers, and the precautions that we're using to care for our patients before and after their transplant are almost feel, they're not normal, but they feel normal to us now. And I've not seen a single patient get a viral infection from his or her visit to the clinic, or his or her bronchoscopy or pulmonary function test, or transplant. There have been just a couple of cases in the literature around the world that have talked about transmitting disease from donor to recipient, but we're so careful now that I don't think that's anything that has to be a significant worry for us going forward. I know there were a lot of questions submitted for us to discuss, and I will get to them all, and that's why I wanted to leave it a bit free flowing here. But I'll hit a couple of them, I think, as I just talked to you here. You've probably all heard about the transplants that are being done for patients who have severe COVID and get a lung transplant. They are exciting, newsworthy stories, so they make it to our top of our attention span. The truth is that there are actually very few such patients. It's probably on the order of 100 or so that have been transplanted in such as for COVID itself in the United States over the past year and a half. Here in Chicago, Northwestern has performed probably more than any other center, and they've done that through basically getting on board with that idea before most other centers were willing or interested, and and um, and then studying and publishing and talking about their experience in a way that has been helpful for other centers to understand what's involved and what to worry about and what to expect. And the reason there are so few patients who are eligible or who go through a transplant for COVID is the following. If you think about it, early on, when someone first gets sick and hospitalized with COVID, they're still infected. They're contagious to they're still infected, and a transplant would only make the infection worse because of the immunosuppression that's involved in receiving a lung transplant. So the first step is making sure that someone wouldn't be infected before you'd ever consider them being a transplant candidate. The second part about the early COVID infection period is that early on, someone still might get better. We all know people in our friends and family circles that have been hospitalized on oxygen, very sick with COVID, and made it through, come out the other end, and many of them back to normal or near normal. I've seen patients come months later and come off of oxygen when they looked like they were never going to do so in those first months of their illness. So active infection, uncertainty, and hopefulness about the possibility that they might just recover themselves are reasons to not transplant someone very early. Then you get to a point where perhaps they are sick enough to remain in the hospital, to not appear that they're going to get better, and that they're otherwise still healthy enough in every other way to receive a transplant and heal and recover and go forward. And so those patients might be on life support machines in the hospital. But having a transplant is more than just having an operation. It's signing up for a new way of life. Lots of medicines that you have to take, lots of medical issues that you're going to deal with. And all of us in the transplant business really like to know that the patient themselves know what they're signing up for, that they know what's coming, and that they're willing to participate in all the ways that are necessary for a successful and healthy outcome. And so some patients who get very sick and are on life support machines are not conscious enough to be able to say that and or be evaluated in that way. So some patients aren't eligible in that sense. But then they might get a little bit better to the point that they're on life support machines, but they're allowed to be woken up and be asked these questions and answer them in an affirmative way that we can now say that they are someone who we'd like to look towards transplant as an option. But at this point also, they might be in the hospital so long and very ill for so long that they may have begun to develop other medical issues that happen in patients who are in the hospital a long time. Other infections, perhaps other organ problems like kidney problems or heart problems or liver problems or problems with their bone marrow, things that might otherwise make us worried about doing a lung transplant. So these other issues get into the picture. And then a real big one is weakness. We need patients who are going to have a transplant to be strong enough to be able to rehabilitate afterwards. And so I guess you can maybe see through my description of things that there's kind of a very small number of people that are through enough of the illness that we think they're not going to get better, but haven't yet developed all these problems, and we're able to talk to them. So this is why it's been such a few number of patients, despite the very large number around the country and around the world who have severe COVID and life-threatening disease. So there's kind of just a small sliver of people that are truly eligible for transplant for their COVID respiratory failure. And so the outcomes of such patients that have been talked about and published so far actually don't look too bad. They have longer hospital recoveries than most patients, and than most patients who have a lung transplant, probably because they all have some element of weakness and some of these other medical issues that have developed. So a longer stay, a longer rehab recovery, but so far so good in the sense of the medium-term recovery and likelihood of survival seems to be about average for a lung transplant recipient. Naturally, we don't know anything yet about longer-term recovery because this is so new. So people wonder, is this new population of people that need a lung transplant taking away or competing with those patients who would otherwise be on the list or would otherwise be in the need of a lung transplant? And I suppose it's true that there's a limited number of donors out there. And for a limited number of donors, there are now a few more recipients that are seeking those same donors. And so, yes, there's a little bit of a change in let's say the availability for organs for patients who have other illnesses requiring a transplant. But at the same time, our transplant community is expanding the donor pool in some other ways. So there are some patients that might otherwise not be donors that we're now looking at as donors, that expanding the criteria for acceptable donors in other words. And there are now evaluation processes using machines where we can put donor lungs into a what's called an ex vivo machine, where they can receive air and they can through a ventilator, and they can receive perfusion through an artificial perfusion machine with a blood substitute, and lungs that might otherwise never have been used because they didn't look good in with all the testing that was done inside the donor can now be looked at outside the donor and for a longer period of time until the transplant team becomes comfortable with such lungs to be usable. And the experience that's been generated with this type of technology over the last 10 or 12 years is showing us that such lungs that might otherwise never have been used can be used in a way that's not only safe, but successful, maybe even sometimes more successful than standard donor lungs. So what's called ex vivo lung perfusion is now expanding the donor pool. And so even if the recipient pool is expanding, the donor pool is expanding too. And, we just are going with the flow in that sense. We are still seeing COVID patients in the hospital in some regions of the country more than others, as we all know. Thankfully, collectively across the country, those numbers are going down, declining, as we see more and more vaccination across the country and within our communities. Some people have asked me, what do we do about patients who haven't been vaccinated and who have a lung transplant? Of course, that was everybody a year ago. And thankfully, I can report to you that I know of very few patients in my own practice. I think it might be 0 or 1 that are not vaccinated for COVID who've received their transplants. COVID vaccination is becoming a standard requirement for lung transplant candidates. Just as it's required already to quit smoking and to be in pulmonary rehab and to have a heart catheterization and maybe put stents in and to have a colonoscopy as part of your preparation and to have hepatitis vaccines and to have many other types of vaccines and to go through evaluations with social work and everybody else on the team. We have many medical requirements for therapies and evaluations that we believe are helpful and in many cases are proven to be beneficial for patients who are candidates for a transplant. And it's not uncommon for a patient to not be allowed to go onto the wait list because they haven't fulfilled some of those requirements. And so COVID vaccination, as we know, is a highly effective preventative therapy for COVID. And we also know that patients who, if they weren't vaccinated, as everybody a year ago, who get COVID after a transplant, we know that this is a much more worrisome scenario than Joe Public out there. People who have organ transplants, especially lung transplants, which is the target of the infection, the lungs, and who get COVID have a much higher likelihood of severe illness and a much higher likelihood of death from the virus than everybody else in the public, general public. And so to require COVID vaccination as a prerequisite for going on the list as a way of promoting a successful outcome has become pretty standard across the country. And it's a purely medical decision for the benefit of the patient is basically the way people look at it. So I think those are the main things I wanted to talk about as just sort of an organized discussion, and knowing that we have another speaker and knowing that there are many questions that people wanted to either ask or have submitted already, I thought I'd maybe open it up and make it more of a discussion. And maybe Charlene, you could be helpful here in asking a few of the questions that were submitted that maybe I haven't touched on yet. And then if there are others from the audience, that's great.
Excellent. Thank you, Dan. Always such excellent and insightful and much requested information. So thank you. And you did touch beautifully on a couple of those questions that came in. So I'm going to stick to COVID for just a couple of minutes and jump to the chat box. I think if I were to summarize quickly, I think we're having some questions about whether someone who has previously had COVID and later passes for another reason, could they then be a lung donor? And then do we have a matching situation, say, like we look at for CMV or something?
Yes. Okay. So can somebody who once had COVID be a lung donor? Well, every donor gets a thorough evaluation, remembering that these are severely ill, hospitalized people who are usually brain dead, but still on life support machines in an ICU somewhere. So it's a rapid, complete evaluation of blood tests and x-rays and a bronchoscopy and many other medical tests that we can do in the ICU. And as we receive donor offers for our patients on the wait list, we look at all of these things and we're trying to decide if the lungs are healthy and if the risk is a good risk for that particular matched recipient. So with that said, we usually look at, with that said, we're now looking also at COVID infection. We're actually looking at active COVID infection. We get all these tests, all these patients are tested not only in their in a nasal swab, but in a bronchoscopy sample, and they're negative for COVID. So we believe that the donors are almost 100% safe from transmitting active COVID to a recipient or to the care team in the operating room, for that matter, through that testing. But your question is a bit different than that, which is, can a patient who once had COVID, maybe months before, be a donor? Well, the answer is yes, but it's a qualified yes, meaning we would still be looking at CAT scans of the donor's lungs And knowing that that history existed of COVID a few months earlier, we're going to be looking maybe even with a more discerning eye on what that lung tissue looks like on the CT scan, what those oxygen levels look like on the blood tests, and what the bronchoscopy looks like when it was performed, to help us think through whether there is really any worry there from that previous COVID infection. There's a little science around this too. Actually, a colleague of mine here at Loyola recently published a paper where he's one of our lung transplant surgeons, but he's also a lung cancer surgeon. So he takes out people's lung cancers. And so he looked at a series of patients who had what's called a stage 1 lung cancer. So it was a nodule that was going to be removed in surgery. But whenever you do surgery on a lung cancer, you don't just take out, exactly the cancer. You take out an area of lung around the cancer as well. And he looked at a series of patients who were having such a lung cancer surgery and who reported having had COVID in the past as well, to look and see if the normal lung around that lung cancer really was normal, if it seemed to have any permanent damage from the COVID. And in this paper, he showed that all of these patients had normal lung, which is reassuring when you're thinking about the question that you just asked: could you transplant? Are people who once had COVID eligible to be donors, let's say? So I think that such information is useful in helping us think about it, but also remember we're carefully vetting all of the CAT scan and other data that we have about any donor when we're looking at them in real time.
Excellent, thank you, that's fascinating. Circling back to something earlier when you were speaking, we have a question regarding someone who does test positive for COVID while actively listed for transplant, then how long wait would they be looking at to be able to reactivate?
Yeah, this has been a moving target, meaning we had a couple patients like in this situation about a year ago. It was like last November, December. And we kept them a long time because it was less known at that point how long the virus might last. And we were retesting these patients and seeing persistently positive tests, which may or may not mean that they're still infected. A PCR test might be able to be positive in a patient who had the infection, but still had some virus particles that might still be amplified in the test to give us a positive test. So with that said, we're now looking at a 14-day period, assuming they don't have any further signs of illness. That's just my program. It's very plausible that a different transplant center may have a different arrangement or a different understanding of how to deal with that question. But I'd say that's probably a pretty average answer.
Great, thank you. Thank you. And we had a couple of questions come in that are quite similar to one in the chat box. So I'm just going to read from the chat box here. What are the risks for a healthy transplant recipient who has received the vaccination and the third dose? What is the risk, I think, for spending time in close contact with an unvaccinated individual if maintaining mask and social distancing protocols?
Well, I'm not going to lie to you. I think it's important that we tell the truth in a scenario like this. So I lost 2 patients in the last week to COVID who had a lung transplant and had been fully vaccinated. And both of them had been both of them had household contacts that weren't vaccinated. One of them was a child who was ineligible for vaccination, and one of them was a spouse who chose not to be vaccinated. And so I think my comment there is very sobering and sad. but I think it very much accentuates the importance of everyone around the transplant recipient being vaccinated themselves. As hard as that may be for some people to accept, this is about, as I speak and as I care for my own patients, that's the perspective I'm thinking about, is from the perspective of caring for the individual transplant recipient. The health of the other people is also important to me on some level, but there's one person I'm really caring for here, and that's the transplant recipient. So I have no qualms about being very strong in my recommendation to the context of people. So with that said, I'm not sure I would require masking and spacing of unvaccinated children in the house with the transplant recipient. I think that's probably impossible. So I think people need to be careful in a way that the general public doesn't have to quite be as careful anymore. And so that means, I think, when you're around unvaccinated people, masking, spacing as much as possible, and avoiding crowds where you don't know the status of people, and remembering that even vaccinated people can also get infected, and while they might not transmit the virus as well as an unvaccinated person, they probably still can. And so I think we just have to, sadly, we have to continue a level of precaution that we wish we didn't have to, but we do.
Thank you, Dan. First, I'm sorry for your losses, and thank you for being open with us. So that this is why we're here, and and it's such valuable information for us. So thank you. As a follow up to that question here, just tracking in the chat box, what about an unvaccinated person who has had COVID? Any change to your response there, or?
An unvaccinated person who has had COVID is not as well protected as a person who's had COVID who has received the vaccine, or even as well protected as someone who's never had COVID who's had the vaccine. Natural infection, while it might not make sense to people, and it might not even make sense to me, natural infection just doesn't provide as much immunological protection as the vaccine does. And so people who've been infected should still get the vaccine as a means of protecting themselves and others. And so I would say, to directly answer the question, if a fully vaccinated transplant recipient is going to be around someone else who has not been vaccinated but has had the natural infection and cleared it, there's a risk there that's higher than being around someone who's vaccinated. I can't quantify how much higher. I don't know if anyone can, but there is a difference there.
Thank you. Thank you very much. And we'll stay on this thread. Just one more question coming in here. If you could please just a word to on this same vein, to our LAM community members who are on Rapamune, but not transplant recipients, little more relaxed or the same.
Yeah. So being on Rapamune, sirolimus, or any rapalog like everolimus is the other one. That type of treatment that is so common in patients with LAM is a type of immunosuppression, but it's not nearly the level of immunosuppression that we give patients with transplants. I would say it's a very mild form of immunosuppression. And so, again, this is not something I can quantify, but there is probably some added risk for infection, but it is not very high. there's actually been a collection of cases from a number of LAM clinics around the world that was organized by Nishant Gupta and others, and it's going to be published before too long. But it doesn't seem that there is a very high risk of severe infection in patients who are on sirolimus compared to the general public. Now, I don't think that means that it's time to go party, but it's still, I can't overemphasize the importance of vaccination for everyone, and especially someone who might have some mild immunosuppression from sirolimus. But I also don't think you have to necessarily live in a bubble. Well, no one needs to live in a bubble, but I think the patient with LAM who takes sirolimus should maintain a little more precaution than the general public, but doesn't need to be overly worried.
Great, thank you. That's very helpful. One more COVID question here. If we have a pre-transplant woman who had her first dose of COVID in April, I believe the second in May, so last spring, or the second in July, I believe. COVID in April, first dose in May, second dose in July. Is it time to get the third shot, the booster, or should she be waiting the 8 months? This is not a transplant recipient.
But it's someone on sirolimus, I guess I should presume. So
yes,
the guidance from the LAM Foundation and for that matter, it's based upon guidance from the CDC, is that anyone who's immunosuppressed, including patients who are on sirolimus for LAM, should receive 3 doses of the mRNA vaccines, which are the Pfizer and Moderna vaccines. They should get 3. And there's a lot of confusion about the so-called 6-month booster. This is different than that. Patients who are immunosuppressed should get a 3rd dose about a month or soon after that from the 2nd dose. So not waiting 6 or 8 months from the 2nd dose, but as soon as possible, no sooner than a month from the 2nd one. So if it was May 1st dose or June 1st dose, July 2nd dose, then we're well past a month, so it's time for a 3rd dose by that recommendation. That, of course, if there are special details to the situation, that patient should confer with their physician to make sure that their particular details don't modify that recommendation. But in general, a 3rd dose for anyone who's immunosuppressed, and it should come about a month after the 2nd dose, and that's for the Moderna and the Pfizer vaccines. And that's different than what came out about 3 or 4 weeks ago from the CDC, which was to say that for patients in the general public who had some special risk, like they live in a nursing home, like they're elderly, like they're frontline healthcare workers and other people that might have a higher risk, that there should be, if you've had the Pfizer vaccine, as of right now, only the Pfizer vaccine, then you should have a 3rd dose or booster dose, and that's truly a booster, 6 months after the 2nd dose. So those are sort of 2 different situations. Different when you're a transplant recipient on immunosuppressants, or even a LAM patient on immunosuppressants, that the 3rd dose would be a much earlier thing.
Great. I'm seeing nods heading, so I think we've got it clear. Thank you, Dan. I'm going to leave the topic of COVID here just for a couple of minutes and jump to a couple of our questions that came in advance. And so if we don't get to your COVID question tonight, we will follow up with you tomorrow after this presentation. We'll try to circle back here. One question regarding the lung allocation score. and the recent changes to it. And I think this question is coming from the diagnosis of LAM being removed from the waiting list urgency measure, as well as the post-transplant survival measure. Could you offer a couple of thoughts on how that was moved? If it was it just low numbers of LAM lung recipients, or do you know if that's going to affect? Yeah.
The funny part is I didn't even know that the LAM had been singled out in such a way until this question came, and I had to go to the UNOS website and read about it and think hard about this, because it's actually it's a very hard question to answer about how it affects. So the lung allocation score is a system built to try and make as fair a system as possible to provide priority for transplant to the patients that are either at the highest risk of dying in the near future on the wait list, and also to try to prioritize somewhat the patients that have the best chance of survival after the transplant, the people that are sort of good candidates for a longer survival. Actually, a 1-year survival is how the system is built, unfortunately, not trying to look at people that have a very long survival predictability. So with that said, LAM has never been one that's been very high on the priority list. And that's because, as we all know, a person can live with LAM for a very long time. Even a person with severe disease has a slowly progressive disease, especially if they are able to remain on Rapamune or everolimus while they're on the wait list. So it's never really been a high prioritization. And I think some small calculation change has happened, in the sense that there were some, I couldn't actually tell whether they were negative points or positive points that were previously allocated, but they're gone now. And it was really small. It was a really small amount in the calculation. I think it was removed. The reason any of these adjustments happen is because we're constantly learning, and so UNOS is always looking back on data from the past several years to see how the prediction models were accurate or weren't accurate, and to create new prediction models for going forward. And so that's where these mathematical adjustments and all the numbers happen. They're always based on data. So the data of the past era was showing us that these adjustments for LAM diagnosis weren't accurate or weren't useful anymore. And so they've erased going forward. And it almost certainly has to do with the fact that there have been a lot fewer LAM transplants in the most recent era compared to an era before that, when that must have been inserted. So the difference is marginal, very, very, very small, and it may have been a positive or a negative one. I can't actually figure that out, but I don't think it's anything to worry about.
Great, thank you. And one more off the topic of COVID here. Updates regarding potential advancements in reducing the need for anti-rejection medication post-transplant. We had a couple of questions about that. What are you hearing about it in terms of donor stem cells being used perhaps post-transplant? I believe a notification came out of UCLA with kidney transplants. Yep. So
for everybody's, to catch up everybody on the conversation here, the medicines that you have to use after a lung transplant, the transplant rejection medicines, immunosuppressants, not only lower your immune system and sort of make you more susceptible to infections, as we've sort of talked about already, but there are other adverse effects on other systems in your body. So it can affect the bone marrow in a bad way. It can cause kidney damage. It can do other things to other systems in your body. And so management after a lung transplant for me with my patient in the clinic largely revolves around trying to juggle and mitigate these complications that begin to happen over time. And so these end up being some of the biggest problems sometimes. And so the dream would be to figure out a way to not need transplant rejection medicine anymore, so that some of these problems might go away or be reduced largely. and we've always needed a higher level of immunosuppression in lung transplants than in other organ recipients because of the proximity of the lungs to the external environment. We're breathing in all of the dusts and viruses and allergens and everything, and it's directly touching the organ all day, every day, whereas the kidney gets to hide inside a sterile cavity, protected from all of that. So that we need extra immunosuppression compared to other organs in lung transplant. So could there be a way to use bone marrow from the donor to, I guess, essentially replace the transplant recipient's bone marrow with the donor's bone marrow so that you won't reject the lungs? It's an interesting idea, and it would be successful. If successful, it would mean that you wouldn't have a problem with lung rejection anymore, although you would have some side effects of getting sort of what we call in bone marrow transplant world, graft versus host disease. So suddenly the bone marrow would not like your other organs as much, and it can cause some other kinds of problems. But at least you wouldn't have to worry about organ rejection from the transplanted organ anymore. So in kidney transplant, they are starting to look at this in some special ways, and but I looked at that publication, and they were specifically looking for they're doing this combined kidney and bone marrow transplant in people that have cancer that requires a bone marrow transplant and who have bad kidneys. So it's not like they're just taking the average kidney transplant recipient or candidate and doing a combined bone marrow and kidney transplant in them. And the reason they don't is partly because of that other graft versus host disease that I just described, but also because in order to have a bone marrow transplant, you have to get basically some powerful chemotherapy. You have to kill your own bone marrow first. If you just give stem cells to somebody in their circulation, they disappear. They don't go into the bone marrow and start to live and create blood cells and everything. The only way you can get that, which is called engraftment, is by killing someone's bone marrow with either chemotherapy or high dose radiation, so that then the stem cells that you injected them find their way into the bone marrow and they have a place to live and grow and create a new immune system for that recipient. So they're only doing that in patients who need a bone marrow transplant for some other reason, like they have multiple myeloma and they have kidney failure, and they're only doing it with a highly matched donor, like a brother or sister sibling. So now think about it in lung transplant. The donors aren't your siblings. You can't be a living donor in lung transplant. So they're strangers. It's all happening very fast. There's no time to, even if you brought bone marrow back from the donor, there's no time to give someone the chemotherapy that's needed or the radiation that's needed to obliterate their bone marrow, so that when you give them the transplant, the bone marrow transplant, that they would have a new immune system. So it's partly on the timing. You can plan a kidney transplant with a living related donor, and plan out the chemotherapy that needs to happen beforehand, and time everything just right so that when they need the transplant, the kidney's there, the bone marrow's there, they do it all and move on. And they've had a few successes that way. I have one sideline here, and that is that there is a clinical trial going on at University of Pittsburgh right now in lung transplant in this scenario. And what they're doing there is they're taking patients who have a bad lung disease and a bone marrow disease. So this is mostly people who have what's called combined variable immunodeficiency. So they have such a bad immune system that their lungs end up getting recurrent infections and go into a type of bronchiectasis, a type of lung disease that eventually can lead to lung failure. So they'll have bone marrow problems and lung failure, or sometimes in people with what's called telomere shortening diseases, where they also might have problems with their bone marrow and their lungs with pulmonary fibrosis. And they're doing something kind of interesting and kind of risky here. They're bringing bone marrow back from the donor and the lungs back from the donor, and they put the bone marrow in the freezer, and then they do the lung transplant, and they let them sort of recover from the bone marrow transplant for a period of some months. Recover from the lung transplant for a period of some months, and then they get the bone marrow out of the freezer, and they purify the stem cells there, and then they take this person who's had a recent lung transplant and put them through chemotherapy in order to kill their bone marrow. And then they do a stem cell transplant, and hopefully they get the engraftment. And now they have a patient who has new lungs and better bone marrow than they had before. And they've had some success stories there, and they've had some bad stories there as well. But it doesn't look like it would be a usable, and those patients, by the way, can stop using immunosuppression. So that's ultimately the goal. And it sounds like a good idea, but it would be a very risky way to do it across the board. So it's sort of a special case kind of thing.
Yeah, thank you, Dr. Dilling. That sounds complex indeed.
It is very complex. And it's only being done there through a clinical trial right now too. It's not the kind of thing that you could ask somebody in another lung transplant program to try and do for you, because it's highly regulated through a clinical trial.
Understood. Yeah, thank you very much. So I think our final question will be much more straightforward for you. Could you please explain, I think there's been some word that is a booster shot a lower dose or simply a third regular dose of the vaccine, the COVID vaccine?
That is easy. It's the same dose of the same vaccine. And mixing and matching vaccines is not yet recommended, and it may be in the future, but as of right now, they're all the same doses, first, second, third, or booster. The only ones that will be lower doses will be the pediatric ones. When they come out, will be a lower dose of the vaccine.
Great. Thank you. As always, thank you very much. And I will probably follow up with a couple of email questions that we didn't get to tonight that are a little more personalized. I'm going to try to, you've got a thanks for clarifying there. So I think that that response got through. So thank you very much, Dr. Dilling. And we have everybody muted, but we can give you a wave, and appreciate your time and your insights into this ongoing pandemic very much. So thank you.
My final plug to everyone and all their
Yes,
families to please get vaccinated. It is so important, so effective, and so safe.
Thank you. Yep. Much appreciated and helpful for many, I know. All right. Thank you very much. And we, at this point, I am delighted to follow Dr. Dilling by introducing our next speaker. Kay Blankenship is a board certified and licensed clinical professional counselor who has worked in the field of mental health and has taught in higher education for over 20 years. Kay has an extensive background in adolescent mental health and has experience in wellness and emotional health screening programming. She is certified as a QPR gatekeeper trainer in the arena of suicide prevention and serves as a suicide prevention and postvention consultant for schools and communities. Kay is currently the clinical consultant and coordinator for the Holt Center for Healthy Living's Youth Mental Health Matters educational program. She also works in private counseling practice in Washington, Illinois. Kay is a first-time presenter for the LAM Foundation, and we are delighted to have her with us this evening. Kay, welcome, and thank you for joining us. I will now turn this over to you.
Oh, thank you for having me. Unmuting myself. Well, thanks for letting me join tonight. So I want to talk a little bit about the pandemic and the impact that it's had on our lives. I'm going to base some of this I'm going to share is some of the research that's starting to be done and has been done more during the time of the beginning with when we were more into the quarantine part. And then also some of it is also working with clients and families, okay, and what I'm seeing. So one thing research has shown is that the COVID-19 has dramatically increased people's stress, depression, and anxiety. When looking at the time period of during quarantine, there was an increase in youth suicide attempts in emergency room and emergency department visits, okay? And I think it'll be interesting to see what the impact's going to be as we go into year 2, especially with pandemic fatigue, starting for people. So when we talk about this, to talk about stress, first of all, we have to talk about what is stress? Well, really, stress is change. And oftentimes, change brings about fear. And the crazy thing, and I'll get into this a little bit, is that our bodies and our brains don't know the difference between a good stress and a bad stress. Think about a wedding. How many of you have planned a wedding, been in a wedding, been a part of a wedding, paid for a wedding, right? Or someone going through a relationship breakup or divorce. That is the same amount of stress, but 2 totally different events. One's a positive, eustress, and the other is a negative, distress, okay? So I want you to think about your own individual level of stress when the pandemic began, and I want you to rate it. And I use scales a lot because it helps us know where we're at. On a scale of 1 to 10, with 1 being low, 10 being very high, where was your stress level or fear about the pandemic just when it first began and we were hearing about some stuff in a place called Wuhan, China? So pick that number. Was it low? Was it high? For some people, that was just a vague worry. I have family in Montana. I'm from Montana. I'm in the middle of Illinois. At first, I think that was more for many Americans. We're kind of ethnocentric. That means we think about ourselves only. And I think people on the East Coast, those of you viewers, when it was found in New York, did that start changing different people's views? One of the things, our stress level can change, it can go up and down, and it's different for each of us. I'm not going to get political, but I do, and I'm going to try to remain neutral about vaccine mandates and mask mandates and that. But I think for many working with families, especially with those with people with immune compromised members in the family, that it's their own personal experience has really impacted, right, their level of stress. So think about it. We have all globally experienced the same event. We're all in this pandemic, but each of us have a different reaction. When I talk about stress, what I like to do is I have a picture of a roller coaster. So right now, I want you just pretend this can happen. All right. Charlene, you in Wyoming, the snow is melting, but guess what? There is a giant roller coaster outside your building right now. Okay. Everyone's going to have to get on it. You don't have a choice. We're all going to get on this, and it's fairly safe. I think it'll be okay. All right. So where are you going to sit? I will let you pick where you want to sit. How many of you want to sit at the front? How many are going to sit in the middle? You don't really care where you sit. How many of you are going to sit in the back? And a few of you are going to be like me and I'm going to try to crawl out the window right now. So I don't have to get on this thing, right? So when I do this, I usually flash up this picture of a roller coaster. And then the very next side is one person screaming in excitement, the person next to him screaming in terror, and the other person's acting bored. And they're all these 3 really, tough looking guys, right? They all experiencing that roller coaster ride. For some of us, we're thrill seekers. The thought of a roller coaster is a thrill. We'll be up in the hands in the air in the front. For some of us, we're going to be, no way, I'm not even getting on it. And some people, it's not a big stress, not a little stress, kind of neutral. Okay. So I think about our own experiences really impact that. And I think for many of us, I want to be sensitive to the fact that we have, through death and COVID, lost loved ones, family members, colleagues. All right. And it really has impacted our level of stress and fear. So when you look at it, has your stress level and fears of the pandemic gone up and down? And we'll talk about some of the things that can impact that. One of the things I'm noticing is that the stress and change that has happened, even when we look at how we deal with the idea of death and grieving. Think about hospital visits for people who are sick. You know, I work where I work at Hall, we're part of a hospital system, and we had to screen people. We had to not let family members come in. And even thinking about working with families that were very limited. You know, when this first began, I had some friends who had a death in the family, and it wasn't COVID, but during COVID, they were only allowed 4 people to attend. And they had a massive family. How do you pick, right? Those type of things. All right. Other things I want you to think about. Right now, think about how has the vaccine impacted your stress level? Has it decreased it because it's a sign of hope, right? How about being allowed, for many of you that were allowed to work remote? For many people, that reduced stress. Going back to work in person, reduced stress for some, increased it for others, right? Mask mandates. They created, I think, especially when I think about the immune compromised community, mask mandates were a good thing for them. They want to be safe. They want their family members to be safe. And when those get lifted, right, it can change that. Even masks, how about the vaccine mandates for employment? Okay, depending on where you sit on that issue, it's an increase, decrease, or maybe it's no stress. It doesn't affect you at all. Okay, even simple things about how we learn, how we worked, if we had a job, many people lost jobs, the unemployment benefits, starting, stopping. I look at what now the teachers are dealing with going back to school. It was a great stress and concerns for them being in school. And now they're back. And many of my teacher friends are saying, I'm trying to teach last year and this year to keep up. And I have this fear that I'm going to make my kids sick. You know, I don't want to hurt someone, right? So thinking about it, I think of my own private practice setting. You know, now we closed, we reopened. And I think for me personally, the vaccines have, my adult clients, for many of them, it's reduced their anxiety, right? However, there are many of my clients who won't allow their children who are of age to get the vaccine because of the information that they've received, that many of it is maybe not accurate, and fears and things like they hear rumors and things about that their children will be sterile if they get the vaccine, right? So part of it, when we think about all of this has hit our mental health, and I saw a real dramatic increase in depression and anxiety of my clients and a frustration at a new level when this fall hit and we hit another wave. I think there was a sense of hope for people over the summer. The vaccines came out, and then because people weren't vaccinated for many, and we had the waves, I think that brought some of that back. Okay, so part of that, I think when we get this, I think for some people too, there's a great frustration that something that's a public health crisis became political, and it's had an impact on us, right? And it's the first time in the US we've had a reaction like this, and it's very, very different than when the US dealt with the polio epidemic. Everyone was united and wanted the vaccine, you know? So COVID has changed the way we live, the work, our interaction, and it's also changed our relationships. And there's been a lot of loss with that, okay? And I think the thing about loss, if it's not a physical loss by death, people don't recognize it as a loss. And that creates all kinds of stress and disconnect and impacts our mental health, all right? Humans are social creatures. If right now I flashed up a picture of a little puppy that looked sad and was whimpering, or a baby crying, our natural instinct is to offer comfort. We talk in a baby voice, we try to make it better, right? We're programmed through evolution to do that because humans are not meant to be in isolation. You know, that is kind of an evolutionary thing that research has found, that it draws us. This sad emotion on someone's face will draw us to them, someone crying to offer comfort. And we need that to survive. So I think the very thing about the isolation people have had to deal with has had a real devastating impact. I think about the youth. This developmentally, they're supposed to be leaving family and siblings. They want to go interact with their peers. So they eventually leave the nest. And to put them back at home and take away their social connections, that has really some real negative impacts. The other thing, think about social distancing and isolation, and even the relationship change we'll talk about, and the divide between the challenges of keeping your family safe and how do you interact in those relationship chains with people who maybe don't take the same precautions about being safe, okay? So one of the best ways to cope is that we can identify these losses, acknowledge them as grief, and also be able to mourn. And I'll talk about the difference between what grief is and what mourning is, okay? So one of the things too, we tend to minimize, we don't acknowledge the loss, we judge ourselves, or we're very dismissive, okay? We as humans tend to be harder on ourselves in our negative internal dialogue and talk than we are on other people. So if we're dismissive or say, oh, but I don't have as bad as so-and-so, right? That doesn't really help us. It just adds a layer of guilt or shame for having these feelings, right? So one of the things I'm going to talk about is mindfulness and how do we acknowledge feelings without judging ourselves, okay? Self-care and self-compassion can be such a challenge for us. So if we can work on that self-dialogue, how we talk to ourselves, catch ourselves, because it's really wild. We're hardest on ourselves and we are stuck with ourselves for the longest time ever, right? Okay. So when we think about the different types of loss, I want you to think right now, oftentimes I would have people journal, and a brain dump is what I call, you just list, you don't even think about it. I've experienced, these are my losses, A, B, C, D, and you just keep going and get them out. And there's not a judgment, you just state them. And sometimes we don't even realize or think about it until sometimes just that simple act of just putting it down on paper or expressing it. All right. I think there's some categories of loss of freedom. How has your lives and our freedoms changed, and how are they still a loss? And what freedoms have you gained? Remember, each of us in our family situations and our circle of friends, it's different, and we may have different reactions, and it may go up, it may go down. Okay, I think about, during quarantine, the foster dog rate went up like crazy. People got kittens and puppies and animals. And now what we're starting to see is that many people going back to work are forced to rehome these pets that they had. Research is showing that the divorce rate and the domestic violence rate went up, okay, during quarantine. And think masks, the vaccine, things that seem like safety precautions and a good thing for someone else cause such distress and they see it as a violation of their rights. They see it as something that's going to harm them. Someone's going to put a chip in them and monitor them if they dare to get this vaccine. And all this can really, we used to talk about, my grandma used to say, you don't talk about politics, you don't talk about religion with people, right? Well, now we have this COVID. And I think that the whole vaccine and safety is kind of going into one of those topics. And I think we've experienced a loss of connection, especially if we are still having to isolate or keep ourselves safe or set boundaries and not have certain relationships or make certain choices about going out in public. Okay. Think about isolation, loneliness, and going back to that, humans again are not wired for that. If you want to really punish someone or terrorize someone, and think about wartime, solitary confinement, isolation, it's one of the worst tortures out there, right? Also, loss of ourself. I see a lot of clients that I've been working with, and just even general discussions that we are experiencing a disconnect in who we think we are and how we see ourselves. I'm a kind, caring, helpful person. And the same people, and I think about a lot of people in the medical profession that are working with a lot of people who are COVID patients and those who are choosing not to be vaccinated, they say, this is really a disconnect because I feel like I'm starting to lose my compassion, right? I'm feeling burnout, fatigue. And so sometimes we struggle with a sense of loss and these negative feelings and that loss of sense of humanity. We make judgments about people and groups that we think, wow, I never thought I would feel that way. Does that make sense? And then going back to, we have feelings, and then immediately we're going to shut those down. We're going to judge ourselves, maybe feel shame, embarrassment, remorse, regret. Okay, so I want to think about a journal question or a thought to ponder with your friends and group is, how has COVID changed your self-perception? Has it brought out sides of yourself that maybe you don't care for as much, more negative? Has it also brought out some really positive qualities, how you've reached out and how you've connected and things you've learned about yourself in life? Okay. One thing, just to realize that this experience is going to bring out all kinds of emotions, and it's going to bring out things we don't even realize we're feeling. Anger, frustration, disgust, hurt, regret. This fall again, I saw a major increase in anxiety as more and more cases started being reported, and frustration because there was a vaccine out there. So one of the best ways to cope and improve our mental health is try to acknowledge what those fears and emotions are. I think about, for me, remember, I go back to when our office closed and then opened, my stress level decreased when the vaccines came out and some of my clients were getting vaccinated and I was vaccinated, but I was still anxious and distressed because some of my young clients aren't able to have that vaccine, right? And then I think about it, why was I stressed and distressed? Well, I was feeling fear. And then I would ask myself, what was that fear? Well, my fear is I'm a counselor because I'm trying to help people. I don't want to cause harm. What if I was to unintentionally infect someone, right? So for me to realize that helped me kind of manage that and feel like I take as many precautions, as I can. I try to be safe. And in many cases, I still do telehealth with people, okay? And when we don't acknowledge these feelings and things that we're having, oftentimes it builds up and it's like a pop bottle. When I give talks to kids and adults, I'll have a soda bottle and we stuff all these feelings and things and we shake it. And then I say, here, would you like to open this? I'm really thirsty. And everyone's like, no, that's okay. And what happens is it's got to come out. It's like a volcano. And oftentimes what we find is it comes out in little bursts. We have outbursts. It comes out with those closest to us, right? All right. The aspect of grief, these changes, this stress, the way the world has changed in our interactions and so many changes in our relationships, the sense of loss. We found some relationships and people did not endure when we had to deal with isolation and separating. Other relationships grew, right? But the difference between grief and mourning, grief is kind of like a vessel or a vase. And that's what holds everything we're feeling and thinking. Whereas mourning is the actual act of expressing that grief through tears. It helps us cope it through actions, through our beliefs, through our rituals. And again, that's why I think during COVID, when we could not follow our religious traditions and rituals around death, caused a great distress, okay? And one of the things too, when we mourn, we try to find meaning. One of the best ways to deal with grief is to find a meaning. What is this trying to teach me? What have I learned? How can I find meaning in this loss, this grief? I'm sure many are familiar with Elizabeth Kubler-Ross, the 5 stages of grief. I think they're wonderful. Shock, denial, anger, we bargain and eventually come to acceptance. What we have found is, that was research done on terminal patients with cancer. And I think much of that holds true for us as human beings today. But what we have found, people took this as hard and fast rules, and they expect you to boom through these stages and then you're fine. No, people bounce around. Some may not even have a certain stage, right? I really like to look at some of Professor Alan Wolfelt's work and applies kind of what he talks about, the rights we have when we're mourning. And I think that kind of applies to this situation where we're at now. Each of us have a right to grieve our experience and our losses in our own way. And when we go to others for help and connect, and when others start telling us what to do or how we're supposed to act or feel, that's a great disconnect, okay? If you start carrying you should or you shouldn't, right? Those are cues. When we do those to ourselves, oh, I really need to, I should, I have to, I really need to start exercising. If you can stop and realize that's a judgment and then say, wait a minute, I'm choosing to eat healthier. I'm choosing to go for a walk. It takes some of that pressure and judgment off. I have a dear, dear friend. She's one of my best friends. If I said, I need you right now, and it's a long drive, she would be here as soon as she could, okay? But I learned, in our circle of friends have learned, when you're really stressed and need to vent or just process, she's not the one to listen, because within 2 seconds, and it's kind of a private joke, she will jump in with, well, you know what you need to do. Okay, that never always feels good, being told what we need to do, right? So pick who you can go to, as a support, who's a neutral listener. We also have a right to acknowledge those losses, again, without that self-judgment or judgment from others. If you can't find a support system within your circle of friends, family, find a professional listener. We're paid, we have to be neutral, right? There's also support groups online, and there are ways to connect. All right, and give yourself permission to feel all these emotions. I often have a picture of an iceberg. How much of an iceberg do we see? Just just the little top, right? Underneath is a really big mass. So anger is often our go-to emotion that's acceptable in society. If I am sitting in the ice cream aisle in a grocery store crying, I bet you most people are going to run away from me and think, what is wrong with that crazy lady? If I am mad and throwing a tantrum, they're like, yeah, just get out of her way, right? So underneath, one thing I like to really let people realize, we can feel more than one emotion at the same time. So anger is often our go-to. And then say, but what else am I really feeling? I'm angry because, think, everyone, pick the last time you were really angry. Got it? Okay, what else were you feeling besides anger? Were you hurt, embarrassed, confused, frustrated, sad, rejected? So if we can tap into that, that can make a difference, because also if we can express that to people, because when we're angry and my pop bottle is blowing up at my family, they're going to react right back and their volcano might blow. And then we have a big mess. But if I can acknowledge, I'm really feeling anger because I'm hurt, or I feel, embarrassed. Okay. That's helpful to know, because then we can also not judge ourselves and we can process that embarrassment, Okay. So one of the things is research is also showing the impact of stress on our physical health. There's some wonderful research out of Emory University about mindfulness and breathing, and what they're doing by just breathing and calming our bodies. It's changing what I'm going to give you the short name, IL-6. It's the inflammation in our bodies that we're thinking that long-term can lead to disease, cancer, diabetes, all these different things. So if we can reduce that inflammation and keep ourselves healthier, it's really beneficial. Mind, body, spirit, they really are important. So I encourage you to look at some of the mindfulness, some of the breathing activities that you can do. And mindfulness, we're going to do one right now. I want you to think about, go back to that, anytime if you're feeling frustrated about something, what I call is do a brain dump. Or if you don't know how you're feeling. So to ask yourself, 1 to 10, how stressed am I? Where am I at? 1 low, 10, I am really stressed. And I say, I'm at an 8. Then ask yourself, why? And then don't think, I'm at an 8 because boom, boom, boom. Can't really think about it, just list them, A, B, C. And then you say, oh, okay. And then I want you to do a brain dump of all the things you're feeling. I'm mad, I'm sad. Let's say I asked my husband to, dump the garbage and walk the dogs. And he didn't do it. He didn't get around to it. Okay, so I'm feeling all this and feeling kind of tense. And I have to think about, okay, what am I feeling? So on my list, I'm mad, I'm sad, I'm rejected, I feel hurt. What else? I feel he doesn't listen. Okay, and you put all those things down and then you think, wow, what surprised me? And I almost might maybe feel guilty or a little bit of shame, because he worked the night shift and he had like 1 hour of sleep, and I asked him to get up and let out the new puppy. Oh, okay. So then I think, or think of this. Your 98-year-old grandmother has asked you for the 5th day in a row to come over and fix her remote on her TV. And you're thinking, I'm so frustrated. I'm so tired of this. She's really bugging me. And then you immediately, I should feel that way. Oh my God, she's 98 years old. She made me cookies. She took care of me as a child. Okay, so step back. Mindfulness, you list all that. I love her. I'm frustrated. I'm tired. And then you step back and think, wow, which one surprises me? Which ones am I judging myself? And then you write this. Our feelings are just feelings. They're not good. They're not bad. They just are. So think about it. Do you know anyone who happens to have any road rage? When road rage happens, we become that emotion of anger. We do not do mindfulness where we just acknowledge it. We become it. Or we become that hurt and we isolate and we hold grudges and we won't talk about it, right? So there's a difference being able to acknowledge without judging it. They're not good, they're not bad. This is what we feel. Okay. Lastly, I want to talk about too with that is we can also have grief bursts. Funny things may trigger our grief and a grief reaction. I think about years ago, my father passed away, and it was probably 2 years later, and I was painting a door jamb. Not the time to have a moment of grief. I started bawling. my father and he taught me to paint, and they had a lot of rental property, and I used to get stuffed in a closet because I used to, I guess, say, why am I a bad painter? And they'd say, no, you're the smallest, go paint the closet, right? And it came back to me, and I could see my dad edging trim, and I just started bawling, and I had to call someone and say, this is just crazy, why am I crying? That was a grief burst. And sometimes a commercial, a thought, a feeling, they may just it's like an overwhelmed welling of emotion. And that's okay. Do you know, they did a study. If I had magical powers right now and I blew onion powder in all of your eyes, and your eyes started tearing and tearing, and I took that, your tears, and had them analyzed. And then when you're crying and you're hurt or sad or overwhelmed or frustrated or even happy, and you're crying tears, and I analyzed it, we would find some stress hormones in those tears and some other things that it's a way of body self-regulating, they think, trying to get some of that stress hormone and things out. Whereas if I did the onion powder tears, nothing. So isn't that interesting? Our emotions do serve a purpose, okay? Lastly, because I want to get to discussion and I'm not sure of our time, I tend to talk kind of fast, so sorry, that will leave more time for discussion. I want to talk about resiliency. What is it? The work we're doing, I do a lot of work within the Peoria area, which is a real urban, high poverty, high ACEs, which is adverse childhood experiences, neglect, abuse, incarceration. There's a lot going on for these kids. So one of the things we talk and teach them is about resiliency. And one of the best pictures of resiliency is a dandelion blooming in a crack in a sidewalk. Resiliency isn't something we have or don't have. And it's more about how we deal with what happens in our lives. And it's our ability to adapt and deal with life stresses, basically what life throws at us. I tell kids, I have a giant bag, teachers hate me, of bouncy balls, some big, some little, some really bounce, some hardly bounce, and I dump them out in a class. And I say, look, this is like resiliency. It's not about how high you bounce, because some of these balls barely bounce. Some are all over the place. I say, it's the ability to bounce back. It doesn't matter how high, I can help you with that. So it's something that we learn. It's a skill. We can obtain it. We can always get higher bounce. And it doesn't mean bad things can't happen and won't happen. They will in our lives, but it helps us cope and deal with it. Okay. I think about, I don't know how many of you have ever heard of logotherapy and Viktor Frankl. He wrote a book. He was in the concentration camps, and he came out and wrote a book back in the 60s, In Search of Meaning. And it was all about, again, he talks about our grief and that we're all experiencing life and we're all the process of dying. We're all at different stages. And he said, it's how we look at it. He helped people who were suicidal in the camps. When they liberated the camps, he asked for a first aid kit, and he helped these same guards that killed his family. And I'm misquoting him, but he gave his view is that you can take everything from me. You can take my food, you can take my clothes, my belongings, you can even take my life, but you cannot take how I choose to think and feel about an event. And I think when we can remember that or try to practice that, that's that mindfulness. It can be very, very powerful. And that's resiliency, okay? So one thing I do want to say, if you are struggling, reach out. And everyone has a unique experience. And I think your community, I think it's a harder experience that you're living and enduring. One thing I talk about, when is it time to reach out for professional help? And I say, when your feelings are strong, when they're overwhelming, they're lasting for a long time, and they're getting in the way of home, relationships, school, work, then it's time to reach out and get some help, okay? And I always give a plug for the Suicide Prevention Lifeline. And maybe someone could put this in the chat for me. It's a 1-800-273-TALK, or it's 1-800-273-8255. If you also go to the suicidepreventionlifeline.org, they have a live chat. It's really crazy. Research has found that young adults and kids would rather chat about their mental health and physical health than have a phone conversation. They did a study and they asked kids, can we switch to a phone now during like a mental health crisis line? And the kids would hang up on them. So I think in some ways technology has really helped us through this, but in some ways it still creates some disconnect. The other thing, there is a text line called 741. So when I teach kids, we do the Lifesaver Challenge. So if you want to be a lifesaver, I tell everyone, put these numbers in your phone, because someday, maybe someone you haven't even met yet, you can make a difference in their life by giving it to them. So if the kids want to take the suicide prevention and our Lifesaver Lifeline, they get a Lifesaver if they chant 741, 741, and they put it in their phone and show me. And so the other thing too, some of the warning signs if someone's really struggling, if you see them withdraw, disconnect, stop talking to you, if they're doing risky behaviors, taking greater risks, if you see a sudden loss of interest in things that's their passion that they love, okay? Oftentimes, if you see them wanting to sleep more, change in sleep, change in appetite, you know, those are all things. And you know your loved ones and friends, you know when they're not themselves. And so one of the biggest things about my suicide prevention stuff is it's okay to ask someone. Asking someone if they're feeling suicidal or going to kill themselves does not hurt. That's one of the biggest myths from my generation and older. It will not hurt, it will help. Research has found it lowers anxiety, it stops impulsive acts, and it can give a message of hope. So it's really okay to ask. And if you're concerned about asking yourself, it's okay. Get someone to ask with you. And keep in mind, you can always dial 911 and ask for a wellness check. You need to give where that person lives, the city, the county, and as much information as you can. All right. And also the emergency departments. I know it's challenging. Many people are afraid to go because of COVID. But if someone is really at that point, that is a very critical option. So overall, hopefully you've got something out of this. And I guess right now I'm going to turn it back to you. I can stay if you have questions, or if you want to have your own discussion, I can quietly step out.
Thank you, Kay. Thank you so very much. It's wow, it's a lot to take in. I think I am watching the chat and wonderful feedback and gratitude for you. So thank you very much. We will move into a group discussion. You're welcome to stay. And it is kind of patient-led, but I will presume there might be some questions for you when we move into that. So if you have the time to stay with us, that would be fantastic. Excellent. What we will do at this time, as we have done with previous group discussions in this series, I'll ask Julie to please stop our recording. We do take the recording off for this portion. And ladies and gentlemen, if you would like to open your cameras.